Hi everyone, we are Team 4. Myself, Steve, Dan, Sarang, and Eric. Our application is checked using Google Glass to reduce medical errors. Checklists have revolutionized the way we practice medicine of late, and we think Google Glass can revolutionize the way checklists are used in healthcare. Checklists have a history that starts in aviation and other industries. I think the first ones that they talk about are from World War II when the B-17 bombers first came out, and they were so complicated people couldn't realize what was going on. And in aviation, it's a protocol violation if you don't use your checklists. And unfortunately, a lot of the air traffic incidents involve failure to complete checklists. The Marine Corps wants to reduce errors by 50% through the use of checklists. And why do we need them in healthcare? According to some sites, there are more than 6,000 drugs available to physicians, 13,000 diseases to think about, and over 4,000 medical or surgical procedures to apply when they're confronted with a patient. So it's very, very complicated and impossible to remember everything. And medical errors account for somewhere between 44,000 and 98,000 deaths in the US alone, and the monetary cost is astronomical. If we can get the same kind of gains that people have seen in other industries in healthcare, we can save a lot of lives and a lot of money. And this is one of the more popular ones out there from Atul Gawande. He's at Brigham and Women's. He's a surgeon. He also teaches at Harvard Medical School. This was published in 2009, bestseller in New York Times. And he was part of the group that came up with the World Health Organization surgical checklist. We are going to base our application off of this checklist, which is designed to be done in just a few minutes, standard sets of questions. This has been utilized in many countries, and over 4,000 hospitals use something based off of this. So do checklists work? They reduce complications and death in surgical arenas. Studies have shown cut the complications from 27 per 100 to 16 per 100 patients, because you want your patient to end up here and you don't want them to end up in the ICU. And they also improve in communication between the groups, and that's one of the biggest things that the checklist does, is get people talking to each other. So why not use paper? That's what everybody is currently doing now. Paper is easy, it's cheap, there's minimal training as far as using the checklist. Getting people to do it is a different story, but it's simple. Why not just stick with paper? Some of the problems that you encounter with paper are it's difficult to make system-wide updates easily. You have to go find every copy, pull it out of circulation, and replace it. And making those things can be challenging. Also, with paper, even though it's easy, completion is not good and accuracy is poor. So there's challenges there, and it's not an active part of the medical record. Even if you scan it in, you can't really do anything with it.
So electronic checklists were first proposed in the 1980s in aviation, and they had great success. Some of the advantages are that they allow for system-wide updates and edits to be made very quickly. They're easily integrated into the electronic medical record, and they can be used much more effectively to enforce compliance so that the surgeons are actually completing them. As you can see into the cockpit of a Boeing 777, it's very technologically advanced. There's a lot of buttons everywhere. When they finally implemented electronic checklists over paper-based checklists, they saw a 46% reduction in operator errors from the previous paper-based checklist just by going electronic. So we also have this battle between using glass and just using tablets. Some of the pros for tablets are that they're very portable, they allow connections with electronic medical records and other systems, and they're relatively easy to use. People know what they're doing, as opposed to these glass devices where everybody's looking at them and is confused what they are to begin with. So, but then some of the cons of using tablets are that they're navigating with them in the sterile environments can be very difficult. You'd have to take off your gloves and to navigate them, as opposed to the voice recognition that the glass could use. In comparison with glass, they're much more bulky, and they weigh a lot more, and they're not always there. You have to go and get the tablet, as opposed to glass, which is always going to be there. So it's going to be head mounted right there for you to use, and you're able to keep doing whatever you were doing with the patient to continue treating them in the best way possible. It's staying away from the sterile areas, and it can actually confirm completion and enforce compliance, which all the hospital administrators would certainly love if all the surgeons are doing everything that they're supposed to be doing. So, and additionally, you could also connect multiple glass devices in the same operating room. As you can see on the left, you could have the diagnostic imaging being put into augmented reality so that while the operation is going on, you could have the CAT scan being shown, or on the right, you could have the O2 saturation levels to make sure that the patient is still in a healthy state so that the procedure could continue. We also have the battle for having site markings, so that this could be going straight into the electronic medical record, so there's proof that all these steps were completed. They actually did make sure, mark the site so that they know which limb they are going to be operating on so that errors don't exist like that.
Speaking of the high-level design, this is how our system looks. It's a very top-level view. So user can upload the checklist using the web interfaces on the extreme left, which gets posted onto our central server, which is in our case a Google servers. That's where we store the checklist. From there, the checklist can be pulled off to your glass using the local Wi-Fi network, or your glass can be tethered to your cell phone, through which to the Bluetooth connection it uses the data plan of your cell phone. This is the form which we use to upload the checklist. It is a very simple form. The first field is the activity description, where you put the description of the activity. And right now we are restricting users to only 4 options because glass is having limited real estate. On the bottom you can see 2 options which forces the user to select an activity, and another one disables the multiple option selection. This is how the UI looks on the glass. Right on the top, you have the gestures and the way you should navigate through this app. Single tap moves you up and down. Using swipe, you can change through the options. On double tapping an option, you can actually select. You can see through a green checkbox. We have tried to use the space in the most optimal way because, as I said, the glass is having a very limited real estate. In case if you have a lot of activities, a lot of options to put in, we have found out a easier way to navigate through them. Single tap moves you through the options, and if you have scrolled down the screen and you tap up, the app automatically scrolls you up to the topmost section of the screen.
So we faced a couple of design challenges in coming up with these checklists. One is a design challenge that all checklists face. That's that nobody really likes using them. Particularly, they take a lot of time, and so we wanted to really pay attention to making the interface as minimal as possible so people could get through the checklist as quick as possible. We did some paper prototyping and went through a few rounded revisions to try to cut down the actions that people have to use our interface. One of the other challenges was getting voice recognition to run in the background. We wanted to have it be hands-free. And we had a hard time getting voice recognition to run constantly. So right now it's programmed to use a Google API that uses speech to text. It makes it a little slow and requires a network connection. So we're going to switch gears to a demo now. This is a checklist that we're going to use for our demo. It's the same one that Stephen pointed out earlier. There's 3 phases, and we're going to really focus on the first phase. And that's before anesthesia is induced, but there's other phases afterwards. So our demo is going to have 3 parts. The first is we're going to show the web interface for the checklist. Then we're going to show a video of the checklist in action. And then lastly, we're going to do a live viewing with the app. So first, we're going to do developing the checklist. So development would typically happen ahead of time by a medical professional or somebody doing quality assurance at a hospital. They would research best practices, and there'd be somebody who's an expert in the procedure being done. So we're obviously not qualified to make those, which is why we're using that one that somebody else has created already. So we've made it very easy, though, to enter those into a web interface. So Sunny's going to play the medical professional right now and enter one in.
So we have a very simple activity. Does the patient have a known allergy? And we have just 2 options with it, yes and no. So the important thing to notice here is the 2 options which force user to actually respond to this activity on the checklist. So as we discussed before in the presentation, the compliance, this is the thing which forces the compliance. There are certain activities which you don't want the practitioners and the doctors to skip. So you can enforce selection on this. And there are some activities where you don't want them to enable multiple selections, which can cause confusions in the end. So this is how we are eliminating that problem here. I think that's pretty
Okay, so we're going to go ahead and show you a video of the checklist in action. And in the bottom right corner is what the glass user is going to be seeing during this interaction. I need to turn up the volume. patient, John Doe, is here to have pins inserted for a radial head fracture in his left elbow, which he injured while trying out for So You Think You Can Dance. The surgeon and glass operator will lead the checklist procedure before the patient is put under. There are 3 sections for this checklist. First, the section before the introduction of anesthesia. The second is before an incision is made in the skin, and the third is before the patient leaves the operating room. The operator opens the checklist, and the first item appears.
Has the patient confirmed their identity, sites, and the procedure we're doing today?
Yes, he has confirmed his identity. We are operating on the left forearm, and we have his consent form right here.
The glass user moves the selection by single tapping. A selection is recorded with a double tap. The user can then swipe to the next item. At any point, the user can also swipe back to see previous items.
Has the site been marked?
Yes, the site has been correctly marked for this procedure.
Is the anesthesia machine calibrated and ready to go?
The anesthesia set machine is complete for this procedure.
And pulse oximeter functioning?
Yes, the pulse oximeter is on, and we have an O2 stat reading of 99.
Excellent.
For the next question, we have programmed the checklist to require a response. The user will not be able to move forward without answering it.
Does the patient have a known allergy to anesthesia?
Let me double check this information.
Okay, because we're not able to move on until we confirm this.
If the user tries to move on without making a selection, an error pops up. Once a selection is made, the user can advance.
The patient has no known allergies.
Excellent. How about a difficulty with the airway or aspiration risk?
We expect no difficulties with the airway for this procedure.
The user also has the option of using voice command at any time. Currently, this is implemented by a long tap and then speaking the command.
Is there a risk of greater than 500 mLs blood loss with this procedure?
We do not expect a risk for this procedure.
No.
The user has now completed the first section that needs to be done before the incision is made. We would go through the next steps as the surgery continues. So obviously that was the recorded demo, and we just want to give you a glimpse into how it happens live. So Sunny's going to open it up and show what it's looking like for the interface right now. This is how the home screen looks. So on the home screen, you can see the gestures which you can perform on the app. So a single tap allows you to move up and down through the options. So if you have multiple options, you just tap to move through them. Swipe allows you to move between the activities. Using double tap, you can perform a selection, and doing a long press brings up the voice recognition pop-up where you can speak up a command, say check option 1, check option 2, next, or previous. Right now we are supporting just checking options and moving to next and previous commands. So this is how the home screen looks like. Let's try to do a checklist. So this is the first checklist. So right now we don't have multiple options, so I can just do a double tap to check it. I can move ahead to the next activity. So I'm going to skip through the activities as it is getting repetitive, and we are directly going to the activity where it asks us to mandatorily enter an option because it has been mandated by this checklist. So this is the point. So from the patient's perspective, it is a very important question. So if the physician skips it, it might result into casualties. So what we try to do is we are trying to stop physician from skipping the steps. So you can see there's a validation message which pops up. And if you do a selection, then only you can move forward. So you can go ahead. I'm just skipping the activities. As I said, if you are putting a lot of content on the class, we struggled hard and we did some experiments to find out a way to navigate through them. We initially thought of using the swipe gestures to navigate through them, but it was not working fine. So we thought of using single tap to navigate through the options, jump through them. So this is how it jumps, single tap jumps you. So now it is automatically scrolling to the bottom, but now it once again, if you do a single tap, it takes you back up, so you can keep scrolling through the options. I'm trying to do the voice recognition. Let's see. Check option 1. Boom. So checks the option 1,
And in this way, it can be used hands-free. Right now, we have to do a long press, and the pop-up pops up, which makes the whole thing very slow. You want to run the whole thing in the background so that user can keep issuing the commands next, previous, check option 1, 2, 3, go ahead, so that it makes this whole thing a kind of hands-free experience in the hospital setting. And as soon as you're finished, you just swipe ahead, and it's done. Thank you.
So the takeaways, again, checklists are changing the way that we do medicine right now, and we think that glass will revolutionize the way people use checklists. And some of the future ideas that we have thought about, branching lists to navigate between different types of checklists, maybe in not just the surgical setting, but in other settings, doing audio-visual capture, recording interactions, medical record integration. I think that will be important, because if you can get these things implemented and checked off and updated live into the system, that can be huge. And then also context awareness, knowing who the patient is in front of you and bringing up relevant information at that point. And that's it.
Thank you.
So do you know of studies that have been done that show the media that you use for checklists, if that makes any difference on adherence? Like tablet to paper? I mean, maybe the physical action of checking things off somehow makes it more efficacious for...
Yeah, the electronics have shown greater completion because they can enforce it. But it's still some of the best stuff. One of the ones that I referenced was electronic, and it was only 80% completion. So it's still spotty. There's room for improvement.
And incompletion is like skipping over items? Or...
Yes.
Okay.
Yeah. So there was one study that showed 95% use among when they were introducing it in the UK in surgical theaters. 95% they used the checklist. They only completed 68% of them. So.
And while these seem like such simple steps, there were actually just this past September, there was an operation done on the wrong leg in Florida. The patient had to have both legs done, so the physician claimed that he was doing what was morally and ethically right, because at that time he decided to do the other leg, but it was because they didn't mark the site correctly. So mandating these things and not skipping through the checklist would have made it so they would have done the operation on the right limb.
Well, you said they didn't mark the limb correctly, though.
Right.
So it wasn't the check that was wrong, it was the mark.
They didn't do it at all.
Oh, I see. Okay.
Yeah.
So you said both limbs needed to be done anyway?
Yeah, so
they
both
made
limbs,
excuses, but...
right, so both limbs were very bad, so they seemed similar, so they couldn't tell which one was going to be worse. It's not as obvious as a broken leg where you see that leg needs to be fixed. So this one they were doing, I forget what the procedure was, but they had to have both be done, and they did them out of order, so it worked out in the end, I guess, but obviously it could have been a much worse situation.
That's a great demonstration. Thank you. I just had a couple of questions. I wondered if you could say one thing to help professionals to have them use this rather than the piece of paper with the pen or tablet, pop, 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 go. What would be the one thing that you would tell them why should they use it?
Well, I think maybe it's not ready right now, but the future benefit of if you can have everything right there in your glass device, you wouldn't have to go get stuff. So think of a surgical setting, you're setting up an instrument tray, you could have the checklist, you could have stuff pull up right there, you don't have to stop and do it. You're seeing more checklists come in emergent situations, so if the patient crashes, you have a checklist to go through your options of what you do. So say you're the surgeon, you're scrubbed in, all of a sudden pressure drops, hits this thing. You could open your checklist verbally, and it's right there. You don't have to break and find it, and it's right there in front of you, and it can guide you through what you need to do. So I think that's one opportunity.
Just one quick follow-up question. How would you train people in large scale to use this?
Well, I think surgery is probably a good place to start because most places don't have that many operating rooms, and you could start with a small number of people. They're already using checklists, and they may be using tablets already. So I think if you get some champions, and I think surgeons have been very keen to use glass to record things and broadcast, and it's a great teaching tool. So I think there's already a toe in the door to get it going. So I think you start there and then branch out into other areas. And as you've seen, there's a lot of checklist activity for pediatric stuff, for primary care visits kind of stuff. I think it's going to be harder to get out there, but I think surgery is a good place to start.
And it also just... It also is a matter of the physicians thinking of the checklist in the right way. It's not a recipe for what they have to do for how to treat the patient. It's just the commonly forgotten steps. So it's going to be right there for them. So as it's integrated more easily and is able to recognize it as they're speaking it to the patient, they would be going through so that they wouldn't forget those easily forgotten steps.
Another point I'd like to add another point to what you said. So another thing which we have planned but we were not able to implement was using the collaborative checklist, where a patient and a physician can actually collaborate and check off the options and complete a checklist. That's what we discussed with the professor during the coursework. So that is the another possibility and another realm which can be explored in the future version of this app. Yeah.
Two things. One's more of a sort of point and to think about maybe how you might make your app do this. But one of the things that the VA has done very effectively is to change from a system where there wasn't a lot of accountability to one where performance metrics drive a lot of what goes on. And so I'm wondering if you could, what's nice about the electronic capture, as you mentioned briefly in your presentation, is that can go to some central place and numbers can be generated about how many times the checklists were finished and kind of good things that happen when those checklists are done. So that's sort of just kind of a point to be thinking about. And the second question has to do with a more technical issue, which is that operating rooms are noisy places. So to what extent does your Google Glass pick up just the surgeon doing the checklist and not the nurse over here who says yes, and oops, it checks that, and they're moving so quickly that they don't notice that and something actually gets skipped. So it's kind of more of a little technical question about can it deal with the surgeon's voice specifically.
I mean, that would be something to test, because typically a pre-surgical type checklist, everybody stops, patient comes in, and it's somebody's reading the card or they have the tablet, whatever, and they speak it out, and then usually it's not 4 or 5 people responding at the same time. So we would have to test it in that environment. I think if the voice recognition is running during the whole operation, then that would be a challenge. We would probably have to figure out how to, if it's going to stay on the surgeon and perform other functions, making sure that we don't have that contamination.
There's lots of talking going on,
Yeah.
different groups talking to each other.
Yep.
And that was one reason why we wanted to build in the gesture-based, in case the voice breaks down, we always have another way to interact with it if you need it.
And if you think about what you said about the documentation thing, if you want to go to the far side of things with the legal climate of stuff, you could have glass device, here's my checklist, I mark the site, I take a picture, it's in the medical record, here's our instrument count, we record it with the video, here's I'm closing the wound. You could have all that stuff documented and part of the medical record. So, I mean, opportunity there too.
So another thing which we plan on doing is, at the end of checklist, the doctor has to sign off the checklist by speaking, by answering a couple of questions, which records the voice sample and it gets digitally stored, so it gets associated with the checklist response. So there's no way he can deny it, that he had not done it or he had not complied with it. So that is the other thing which we have. Yeah.
So what about inflexibility? I mean, I guess this is an issue with checklists in general. So you had a required question about allergy. Well, what if you don't know? I mean, what if you need to skip a step or throw out the checklist?
Well, see, checklists are designed to have some stuff that you can't. If you look at the WHO checklist, there's like yes, there's no answer on some of these things. So if you were going to say no, you stop. You don't proceed. That's the way it's supposed to work. So, I mean, we were hopefully enforcing, if somebody's going to violate that and say, no, we need to do this, then I don't know what the mechanisms are to support that kind of thing, because that the policy would say, complete this, you don't move forward.
And what if the patient's going to die otherwise? I mean, you hold up.
Well, I mean, again, that comes into the extraordinary means kind of thing. What do you need to do? I mean, I'm not sure what the legal ramifications are if we didn't complete the checklist, but the patient was going to die. How do we...
A possible solution which I can think of is user can opt out of a checklist by leaving off a small message at the end of it, which gets tied with it, and he states a plausible reason of not doing it, so that it gets tied with it and data can be validated and he can be held accountable for that.
Taking off my glass now.
Yes.
It's something that we thought about, because a lot of doctors don't like them, I think, for that reason, that it's seen as a very narrow linear. But there's a reason for it, right? It's that if you look at a grand total, you'd rather have people do this thing every time than skip it, because the consequences are greater. One of the advantages of digital is that you can potentially have branching checklists. So if this situation, you can go down a whole other set of checklists and you don't have to do the irrelevant ones that don't matter.
And maybe it's a life-threatening situation, you could deviate and go different pathway or a bypass or something, I don't know, something along those lines. I think, Matthew, you're...
This is a naive question on my part, but does timestamps matter, but they be helpful. So the order in which you completed something, the time in which you did it, your ability to synchronize with other vitals that are being recorded by other devices.
In some cases, yes. And the timing thing, I was thinking of this from my own experience. So a lot of times you're waiting for a patient to be consented to come down for a procedure, and you're standing down in your department and you're like, where's the patient? You're calling up, you got to get somebody on the phone, whatever else. If this is electronic and they complete the checklist, then bam, it goes through. An alert can be sent to the other departments that are dependent on that, whether it's an interventional group or an imaging group, to say patient's consented and ready to go, or the checklist is completed, it's a go. So I think those kind of things, these things are supposed to be administered at certain points, like before anesthesia, before you open the skin, before you close. So timestamps do play a role.
I was just going to mention that probably your next step would be pretty intensive usability testing, and there's a lot of interesting work done in testing in surgical simulation labs, and trying to replicate the complex workflow and complex environment and cognitive distractions is going to be a really interesting feature of what to think about next. And one of the applications might also be helpful for is the EMTs, the emergency medical technicians out in the field that need to be able to have hands-free communications. They have a lot of things they have to check off, and also communicate with the medical experts back at home base. There's really interesting extensions of what you've done.
Well, there was one surgery, I don't know where it was, I want to say Alabama, but could be wrong, where somebody was doing surgery with glass and they communicated with a specialist over the phone. I don't know if they had a live video of showing what they were doing, but they communicated and asked for input during real time. And I really think glass has a great potential in surgery, because if you think of a surgical operating theater, and you guys are students and we're doing surgery, okay, I'm going to be looking for, you can't see anything. So with glass, you're right there and everybody's contained, and I think it is. So I think they'll embrace it. And if you can get these kind of features in to improve safety, I think there's a good opportunity.